All right, hello classmates. I'm doing my presentation on the Edinburgh Postnatal Depression Scale. Most of you guys know that I'm a mom of three, but I also have had postpartum depression twice, so I'm familiar with the screening, in my personal life, and so I thought I would do some more research on it and get some information just about, psychological tests and how they're used to measure and keep track of postpartum depression, since that's something that I care about. So before we get into the scale and its history and how it's used, I just wanted to give those of you who are not familiar with postpartum depression or perinatal mood disorders some background info on that. That way you have some context. So the American Psychiatric Association estimates that approximately 10 to 20% of mothers experience postpartum depression. Yet, it is argued that postpartum depression remains underdiagnosed because of women's reluctance to seek assistance, lack of physician expertise in detecting depression, and the difficulty of identifying postpartum depression due to similarities between depressive symptoms and experiences of new motherhood. For example, lack of sleep. So, as far as the history of the test, the Edinburgh Postnatal Depression Scale was first developed in 1987, so fairly recently, by Scottish Health Centres in Edinburgh. So that's where the name comes from. The EPDS, that's the abbreviation for Edinburgh Postnatal Depression Scale, was developed for screening postpartum women in outpatient, home visiting settings, or at the 6 to 8 week postpartum examination. So up until 2017, there weren't many revisions of the test, and it was frequently used to diagnose women, even though it's supposed to simply be a screening tool. So in 2017, the Archives of Women's Mental Health updated the guidelines for use of the depression scale, including that test users remember that the EPDS is not a diagnostic tool for mental health disorders. Furthermore, a high score on the screening or on the scale indicates that depressive symptoms are present, but not their duration or intensity. So the EPDS is not a test for postnatal depression or for anxiety disorders, and that's why, because it doesn't address the duration or intensity of symptoms. So it's my hope that doctors and mental health clinicians develop a better working relationship that will benefit new moms struggling with this. It's also my hope that there will be more of a variety of screening tools and diagnostic tools specific to postpartum depression. Because, that condition can be different from normal depression and anxiety, and it can be treated in different ways. There is a hormonal aspect to it. And in fact, some doctors, Catholic doctors actually, are experimenting with the hormone progesterone and giving women progesterone hormone injections to see if that has an effect on postpartum depression, because there is such a dramatic hormonal shift that happens right after giving birth. So there is a hormonal and medical side to it, which is why we really need OBGYNs to be involved in the research and be involved in the development of these tools. But obviously it's a mental health disorder. So we need counselors and therapists too. So I'm hoping that, this screening, the Edinburgh Depression Scale, has bridged the gap somewhat, but there's still a long ways to go. So as far as current usage, qualifications needed to administer the test, you really don't need any. If the clinician feels that the client is suffering from depression, an appropriate referral should be made, and that's pretty much it. A nurse can administer the screening. I've had a nurse give me the screening. I've also had a doctor give me the screening and be present for it. So they're also widely available online. A lot of postpartum depression advocacy groups put the screening online so that women could even take it at home and then, based on their answers, decide to seek help. As I said previously, it's not a diagnostic tool. It's just a screening to see if someone needs a referral. And the actual diagnosing has to be done by licensed healthcare personnel. So users may reproduce the scale without permission, providing that the copyright is respected by quoting the names of the authors, title, and the source of the paper in all the reproduced copies. So now I'm going to read you the instructions. So it says, the mother is asked to underline one of 4 possible responses that comes the closest to how she has been feeling the previous 7 days. The second instruction is all 10 items must be completed. So there's only 10 questions, very short. Care should be taken to avoid the possibility of the mother discussing her answer with others. And finally, the mother should complete the scale herself unless she has limited English or has difficulty with reading and writing. So why is this test used? Like I said, it's mostly a screening tool. That's why it's so short, and it really is only looking at the past 7 days, even though it's normally given at the 6-week or 8-week postpartum checkup. The questions are kind of limited to just that past week. And in the US, unfortunately, it has been used as a diagnostic tool. So a doctor will see a high score from the scale, and they will just write the mom a prescription for an antidepressant, which is exactly not how it's supposed to be used. So the test can help to filter between symptoms of new motherhood, lack of sleep, for example, and mental health issues that are a little bit more serious, such as wanting to hurt yourself or someone else. So that is really helpful, actually, because a lot of new moms, because they haven't done it before, had a child and tried to raise a child, there is a lot of confusion, and they don't know, what's normal and how much of their symptoms can be attributed to lack of sleep versus something a little bit more chemical, an imbalance that they really need counseling for. So the screening tool actually is really useful to women to decide, whether or not they should reach out, which is why a lot of postpartum advocacy groups make it accessible online, because that's usually how women can see, like, oh, wow, no, this is something that needs to be addressed by someone with a little bit more training or information. So the weaknesses, there's quite a few weaknesses, unfortunately. So there are specific aspects of it that continue to be questioned both by counselors and doctors, just in terms of the length of time that it's examining. So just the mom's past week, and is fairly short, but also the cross-cultural validity of the scale with respect to the metaphors it employs and the meaning of the symptoms to different cultures. And then also the misuse of it in practice by doctors in various places. So these debates prompted 2 of the original test developers, Cox and Holden, to publish a handbook about the application of the Edinburgh Postnatal Depression Scale in clinical practice. So their book discusses the need to address issues of sociocultural equivalence when it's being used outside of the UK, because it was originally developed in the UK with that demographic in mind. And also when it's translated into different languages, rather than how the English version of the scale may be understood differently in Western cultures. So obviously in America, we speak English just like they do in the UK, but there is still going to be some subtle differences that are maybe very nuanced, but still important, right, when you're administering it to somebody else. So also, there needs to be a thorough understanding of the cognitive processes that underlie women's responses to the questions on the scale. So that is super important when you're, implementing these things in that context. So a lot of the errors also depend on the interpretation of the test giver. So what this research indicates is that practitioners should not simply accept the results of the EPDS as unequivocal, but consider what they feel, in the self-assessment that the woman has done, if it accurately reflects her mental health in the postpartum period. We've talked about how tests can be positively skewed or negatively skewed, or if someone's trying to make themselves appear worse than they are versus better than they are. So that is up to the clinician, and because it's not someone administering the test necessarily, you're just kind of giving the paper to the woman. I would say that there's definitely more of a risk of that, and so practitioners should be vigilant, I guess, and maybe come back to particular questions, and ask a woman to maybe explain her response and kind of make judgments based off of that too. So now I'm going to go through and read you some of the questions that are on the screening. Since it's so short, I'm actually going to read you all of them. So the first question is, I have been able to laugh and see the funny side of things. And the responses vary from as much as I always could, not quite so much now, definitely not so much now, and not at all. Number 2 is, I have looked forward with enjoyment to things, with answers varying from as much as I ever did to hardly at all. Number 3 is, I have blamed myself unnecessarily when things went wrong. Number 4 is, I have been anxious or worried for no good reason. Number 5 is, I have felt scared or panicky for very no good reason. Number 6, things have been getting on top of me. Number 7, I have been so unhappy that I have had difficulty sleeping. Number 8, I have felt sad or miserable. Number 9, I have been so unhappy that I have been crying. Number 10, the thought of hurting myself has occurred to me. So as you can see with the way that these questions are worded, it definitely could be interpreted in different ways, in different cultures, or even among different areas of English speakers even. So I think that I'm glad that they wrote a handbook, right, to kind of clarify some of these things, but we're still a long way away from having a perfect screening tool. And maybe a perfect screening tool doesn't exist, right? There's always going to be some margin of error, but we have a long way to go with this one. And it's fairly new. 1987 is fairly new. So it's good that they've already, seen some of the flaws and started to address those things. The one thing that I can say I'm happy to see is that this screening, it's definitely the go-to tool for a client who is struggling with postpartum depression, and it's used worldwide. So that's pretty impressive that, we only have one screening tool. It was developed by just a few researchers in the UK, and now it's used worldwide to treat this, this mental health issue. Postpartum depression is found in all cultures, even from tribes in the rainforest to people in big cities. So it's very common. It is found in, all time periods. So with that in mind, though, I am surprised that we don't have more tools, because it's timeless. Women in every culture and every level of wealth experience this illness. So I am surprised that we don't have more tests and screening tools and diagnostic tools and assessments for it, because it affects 50% of the population. So my hope for the future is that this particular screening will be a little bit more fine-tuned, and that we will also have additional resources and additional screening tools for that. Of course, Beck's depression and anxiety inventories are extremely helpful, and I'm not saying that other tools can't be used for the treatment and screening of postpartum depression, but still, because it is such a specific illness, specific in the time period in which it occurs and with the population within which it occurs, um, I would like to see more assessments that are directed specifically for that. So thank you guys for watching my presentation, and let me know if you have any questions or want more information on that.